CYC is a free channel, presents the Word of God for everyone. Your support will help us to continue the mission. Visit our website, cycnow.com. Even $1 will make a difference.
Hello and welcome back to another episode from our series on CYC MD Part 2. Previously, if you recall, we met with different healthcare providers, all of whom gave us insights into their careers as well as a brief discussion into their education. In this new and exciting series, we are indulging and digging deeper with our professionals and our doctors into more of their focused areas of practice. Today, we will be talking on the topic of prostate cancer. Prostate cancer is the most common cancer among men. And just to give you a rough idea of statistics for prostate cancer, about 233,000 new cases of prostate cancer will be diagnosed. With us today, I'd like to welcome Dr. Hani Ashamullah. Welcome again, Doctor, who's the chairman of Radiation Oncology at New York Methodist Hospital, as well as a clinical professor at Cornell University. Welcome, pleasure to have you.
Thank you, Mary.
So our topic today is on prostate cancer. And I did mention that it is the most common cancer amongst men. And we know very little about it, and I want you to help us shed some light on it. So to start, where is your prostate and what is its function?
So every boy is born with a prostate. The prostate does not develop after birth. The prostate is a small gland in a man of age 40, almost about the size of a lemon or so. Mm-hmm. The prostate is situated behind the urinary bladder, so where the urine sac is, and in front of the rectum where the stools come from.
Okay.
Through the prostate, there is the urethra, which is the channel where the urine passes through.
Okay.
Basically, it hugs the urine tube that comes from the bladder to reach to the outside. Mm-hmm. The prostate gland functions probably in fertility more than anything. Most people believe that the prostate secretes a certain enzyme, fluid, that makes the sperm swim easier, faster, and continue to be healthy. So it almost produces a very healthy with nutrients to the sperm for the sperms to be functioning well in order to fertilize an ovum when time comes. Beyond that, it may have a small reason to help in sexuality, like erection and ejaculation, but really its function is not important beyond the fertility and sexuality. And that's why beyond a certain age, if the prostate is removed, as far as fertility will not affect, but it may affect other things.
Mm-hmm. So as far as prostate cancer in general,
yes.
Is it common in any age or just as you get older?
Good point. So the most common age for prostate cancer is above the age of 60. Mm-hmm. However, you can find it from the age of, say, 40 or 38 till the age of 85, 90. There was a study that was done for men who had autopsy. They died from heart reasons or whatever. And when they looked for men over the age of 80, there was a very high percentage of prostate cancer in them, which was not evident in their life. It did not manifest itself. It wasn't aggressive. But if it happens in the earlier age, it will be quite aggressive. So most commonly over 60, but we have seen very young, and we have seen much more commonly in older age.
So what are some screening or testing for prostate cancer?
So the screening in today's age is being doubted by some authorities that it's not important. We still believe men who have family history of prostate cancer or breast cancer in their moms or grandmothers, men over the age of 55 should get a PSA. And a PSA stands for prostate-specific antigen. It's a blood test, simple blood test, very easy to be done. Result comes same day. And if it is high, the prostate needs to be biopsied, meaning you take a piece from it. Now, as I said, some authorities today are doubting the significance of screening, but there are some people also claim they are wrong. So the jury is not out, but most of us still recommend to do PSA if there are family history of cancer or patient becomes closer to the age of 55 and above.
Now, for a man who's taking medication for an enlarged prostate, which the term they say is BPH, for benign prostatic hyperplasia, should they be concerned for prostate cancer?
Okay, so there is no relation at all between an enlarged prostate, which happens almost in 100% of men over the age, say, of 50. Every man over the age of 50 has some element of BPH, which is benign prostatic hypertrophy. However, that has no sort of relation to the development of cancer. The prostate gets larger with age. Men will have urinary problems with age. They want to go fast to the bathroom. They want to wake up during the night to void. But that doesn't mean their prostate is malignant, or it doesn't mean that the enlargement will result in cancer. No relation at all.
Okay.
So these medications could be given because the flow of urine is difficult, and once they take a medicine like Flomax or something, their flow is better and they are functioning better, but that has nothing to do with prostate cancer.
So you did mention that they should get a PSA, but what are other diagnostic factors?
So once there are two things prompt a biopsy. A PSA that's over 3 or 4, and or a prostate exam. A prostate exam, a doctor could be a primary doctor. It's a sort of not the most pleasant test, but usually the doctor puts his finger in the rectum and feels for the prostate. As I told you, the rectum is like this and the prostate is on top, and I'm sure you will see the pictures. So once we put my finger inside, I can feel the prostate. If there is a bump in the prostate, a nodule, a hardness, then we ask for a biopsy. A biopsy is done through the rectum again, because right through the rectum you can get to the prostate, and they take many pieces, about 12 or at least 12, sometimes 16, and then they study each piece. It's coming from every corner of the prostate. If there is cancer, then we come to diagnosis of prostate cancer.
And you mentioned before that doing a biopsy doesn't necessarily spread the cancer.
No. Again, that's a myth that a lot of people believe in, and it's not proven in any literature or science. Taking a piece of the tumor or even opening to get the cancer out, I know a lot of our culture, society in Egypt and maybe other places believe in it, but there is no basis for it. So if you have a reason for a biopsy, you should not be scared that the cancer will be spread by the needle.
I just wanted to get clear on that.
Thank you. That's a good point. You made it.
We're going to stop for a short break, and we'll be right back with Dr. Hanny, who will continue the conversation and the talk on prostate cancer, and we will be discussing treatments and other recommendations for this. Stay tuned. Welcome back. We are back with Dr. Hanny Ashamullah, who's a chairman of radiation oncology at New York Methodist Hospital, as well as a clinical professor at Cornell University, and we are continuing our discussion on prostate cancer. As we mentioned, prostate cancer is the most common cancer amongst men, and we did mention a few screening methods of seeing your doctor and getting a PSA done, as well as a biopsy done should the PSA be within that range of a 3 to 4. I'm right.
Above 3, yes.
Or above. Okay. So now we are continuing, and I'm sure, again, when it comes to somebody talking to a doctor, they want to know their first thing is treatment. What is their treatment, and what measures should they take? Surgery, chemotherapy, radiation?
So before we get to treatment, we usually almost categorize prostate cancer based on a stage, but also based on how high the PSA and how bad the biopsy looked like. And there is a scoring system called Gleason score that takes the worst cancer and give it a score of 10, and the least aggressive cancer and give it the score of, say, 5.
Okay.
And we call a high-risk patient if he is 8, 9, and 10, an intermediate if he is 7, and a low risk if he's 6 and lower. Okay. Also the PSA, if he's over 20, he's a bad risk, 10 to 20, intermediate risk, lower than 10, low risk. Then we look at the stage. Stage meaning the cancer to the prostate only, did not go anywhere else, stage 1. And that's most common today, men come to us with stage 1. Or a cancer spread to the bone, stage 4, in between whatever happens. Either the cancer is still in the prostate but went to the sides. Once we get all this information, we start offering the patients certain modalities. If he's an early stage, low risk, Gleason score 6 or 7 and lower, PSA 10 or something around that figure, he can have surgery alone, he can have seeds alone, which I'm going to explain, or he can have radiation therapy alone, not necessarily two things.
Okay.
Now, the surgery is a big surgery, but in today's age, they can do it robotically, so they don't open up. They just make 3 holes, one here, and one there. And they remove without opening the abdomen anymore. So it's called the robotic radical prostatectomy. And I'm sure you may invite a urologist one time to speak about it. This is a very important surgery, and we have in our church very nice urologists who perform excellent surgery. So they remove the prostate, they remove the seminal vesicle where the semen is sort of stored, and that's a curative type of treatment. The second way is inserting radiation seeds inside the prostate. Those are very tiny little, almost like rice, radioactive sources. We inject them into the prostate. They keep emitting radiation to kill the cancer while the radiation seeds are dying out. So in about 4 months, no much radiation, and most probably the cancer is killed by that time. The third modality is external radiation therapy, which is given from outside. It's like a huge machine that you will see its picture. And The external radiation is given 5 minutes a day, 5 days a week, for 8 weeks about. Long course, but very well tolerated, and I'm sure we'll be talking more about effects and side effects. So the three modalities are very equivalent in their results as far as prostate cancer when it is early cancer. Mm-hmm. Once you get to a later stage or a more aggressive cancer or a higher risk with a higher Gleason, this is where we need more than one thing. We do radiation plus seeds, we do hormones plus external radiation. If we have to do surgery, some of these men still continue to have radiation after. So it depends on how aggressive the cancer, and then we categorize it, as I mentioned. And then early stages gets one modality, later stages gets sometimes 2, sometimes 3 modalities.
So I know you mentioned actually the seeds implant.
Yes.
And we hear that also our previous New York City Mayor
Yes.
Giuliani, who was diagnosed with prostate cancer,
Correct.
received this seed implant. What is that, and how new of a technology is
So
that?
it's not new technology at all. It probably has been in radiation therapy field for over 30 years.
Okay.
However, it has been perfected and innovated, and it's now very computerized, and the software today is even better than when Mayor Giuliani received it. But the news said that Mayor Giuliani received the radioactive seeds, and at that time, a lot of men were coming just to receive radioactive seeds because they felt if it worked for the mayor, it should work for me. But how it is being done, again, we don't cut open. We don't open with a knife. We don't use a knife even. But we insert seeds under full anesthesia. The patient has to completely be anesthetized from the waist down.
Okay.
And we inject radioactive seeds through needles placed almost in front of the rectum. Many needles, sometimes 15 needles, are placed there, so it cannot be done without anesthesia. And through the needles, we deliver radioactive sources based on the volume of the prostate. So a bigger prostate will take much more number of seeds. A smaller prostate will take, say, 30, 40 seeds, while a bigger prostate will take 80 seeds. Mm-hmm. Now, these seeds are distributed, and they are platinum shelled. Each radioactive substance called iodine, 125. That's the radioactive source. So iodine 125 seeds are almost, as I said before, very tiny, but they have a platinum shell, houses the radioactive iodine inside. And we insert them without cutting the skin. We use a computer guidance to tell us where to place the seeds in order to deliver a very high dose to the prostate with very little dose to everywhere surrounding. So actually, these patients leave the same day, and they have very little side effects. Usually they go to work the next day. And it's a very good modality, but you must select the right patient. Mm-hmm. You can't have an advanced patient and you hope the seeds will work, then you will be mistaken.
So just to clarify again, in order to be able to get this seed implant, you would have to be, I guess if you were to categorize it into a stage, what stage would you say?
So not, as, of course, stage 1, but you are absolutely right. You need to categorize it as a low or maximum intermediate risk. I wouldn't use a high risk when the Gleason score 9 and 10 or the PSA is 50, and I hope that the seed will work.
Okay.
The seeds will not work because once you get to higher risk or more advanced, as I mentioned, the cancer may have gone already outside the prostate. Imagine the prostate is like an apple, but then there is cancer outside the shell. The seeds will only be inside the apple. It will not go outside.
So it defeats the purpose to
Correct.
even use that method
Correct.
in that case. So as far as chemotherapy goes, what are some of the major side effects that are associated with the drugs that are used for that.
You mean chemotherapy, right?
Chemotherapy.
So strangely enough, that's a very common mistake. Chemotherapy has very little role in early prostate cancer, which is 75% of the patients. Only in stage 4 or when the cancer comes back, and even then we try not to use chemotherapy unless hormone therapy fails. Remember, prostate cancer is hormonally dependent, exactly like ovarian cancer or breast cancer in women. So we give medications to lower the testosterone in these men. Okay. And sometimes when we do this, the cancer sort of become less aggressive. If the hormones don't work and the cancer is spreading in the bones, then we give chemotherapy. So the chemotherapy, while has a major role in many other cancers, it has a limited role in prostate cancer and limited to very advanced, metastatic, or recurrent.
So what is, I guess I would say, is the survival expectation, percentage, or rate in prostate? If I'm not mistaken, prostate cancer, I guess once if I'm not confusing it with another cancer, they say once you reach that stage 4, percentage is not so high of survival.
So you are right and wrong. You are right that generally speaking, prostate cancer, they live very long. Actually, there may be no difference between a person who was treated for prostate cancer and another person who never had cancer.
Okay.
So they may completely live and get cured. And their 15 years survival is maybe comparable to a person who never had cancer. But that applies to low risk mainly. Once you get to high risk, and more importantly, that's where you were right, a metastatic prostate cancer that went to the bones, we don't cure these patients. However, they continue to live longer, but they never get cured. Of course, they die of their cancer, unfortunately, but you can have 3, 4, 5, 6 years of surviving with metastatic disease, with the advances in medicine. Unfortunately, we don't achieve cure in any of these metastatic cancers, or at least, I should say, the cure is very rare.
Now, you gave us the diagram earlier when I asked you of where's the prostate and what its function. Now, how common is it? And you said that it's very close in relation to the urethra and all the urinary bladder. How common is it for someone to experience urinary, rectal, or any sorts of bladder problems?
You mean due to the treatment?
Due to treatment.
Oh, good question, actually. So actually, in low-risk early prostate cancer, what makes patients choose surgery versus seeds versus radiation sometimes are the side effects and not the treatment, because the treatment is equal in the 3 modalities. So most of surgical procedures, the ability of sexual preservation becomes 50% and less. There are some procedures can preserve the nerve for erection, but a lot of times it's difficult to do it, especially if the cancer is large or the prostate is big. So that's one item where surgery has more effect on loss of sexuality than other modalities. The second thing, and let me finish surgery first, surgery will start with some problems in the urine but becomes much better after a month. They don't have much rectal problems. Now, if you move to seed implant, the radioactive seeds preserve sex probably the best out of the 3 modalities. However, they have more urinary problems, but very little rectal problems. Urinary meaning they want to go to the bathroom more often. They have something called urgency. When they feel like they want to go right away. They can't hold it too long. Most of these symptoms get better with time. After 3 to 6 months, when the seeds are not hot anymore, they get better. External radiation preserves sexuality a little less than seeds. have somewhat urinary problems, a little less than seeds, but a little more rectal problems. You can have diarrhea, you can have occasional rectal bleeding. With so many new technologies nowadays, the side effects in the three modalities are becoming less and less.
So just to wrap up, again, I think cancer, of course, is very tough to deal with for the individual as well as the family that's going through it with the person themselves, with the patient themselves. What advice would you give the patient as well as family members?
So, prostate cancer, a lot of men want to take it alone because they feel it's part of their manhood, and sometimes they don't want to bring their daughter or their wife. And I find it a lot more useful for men that they are accompanied by their wives when they go to the doctor to check why the PSA is high. I'm going to have a biopsy, the shock of the biopsy. Even sometimes the biopsy is negative. Not every biopsy shows cancer. But all of these factors, if you have a support mechanism within the family, it's a lot better handled than a standalone person who comes to the treatment, to the biopsy, to the diagnosis, to the discussion, completely separate. Of course, among the church and the Christian fellowship, it's even another layer of help when his friends go with him, or his pastor, or the servant in the church, or somebody, it may not be, it doesn't have to be advertised all over that he has prostate cancer, but his close Christian group who pray for him, who attend liturgy with him, who go with him when surgery is needed or a procedure is needed, going through communion before a procedure, ask Abuna to the priest to give him the sacrament of anointment of the sick. All of this are so important support mechanism, and keep the faith strong, because once you hear cancer, in spite of all the cures that we all believe in and we have it, it's shocking to the family, not just to the person. And we cannot underestimate that this is not an easy word in today's age, even though we can cure many of them.
Thank you so much, Dr. Hani.
Thank you.
Appreciate it. Pleasure to have you again.
It's my pleasure.
We hope you enjoyed our episode today on CYC MD, touching on the topic of prostate cancer. We hope we answered many of your questions in regards to screenings, guidelines, treatments, and other advices. We know, as Dr. Hani mentioned, dealing with any of these cancers isn't easy, and we do recommend that you either be and support your loved ones, or if you can't, be with them physically as they go to the doctor, to even just say a small prayer for them. Until next time, have a blessed day.